So, the future of CAMHS transformation. This should, I tried to animate a question mark into this to appear, but I couldn't do that. So some of it is sort of telling you about what we have planned in terms of this, because as Andy said right at the beginning, there is this kind of potential cliff for CYPI, so the funding runs out in 2015. There's been a huge amount of progress and good work to date. It would be awful if it did all just grind to a halt post-2015. And there's two things we could do about this. One is we could get terribly depressed and think that would be awful, but you know, this is the way of the NHS. But, or we could say, well, each of us in the room have something that we can contribute to making sure that it goes forward, and what is that, and how do we make sure, and you know, so I hope we don't end up by the end of today feeling really depressed by the whole thing. So this is, the good thing about being a part of a collaborative, so lots of different people involved in this project, is that you can nick slides from other people. So here's one I nicked earlier. So this is a sort of image of the sort of ambition of CYPI. So it's about whole service transformation. So this is current CAMHS. Not bad, quite a nice big house, but a bit derelict, could do with some improvement. So the ambition of CYPI is to kind of turn something that's all right already into something that's really good. That's the kind of ambition. So it's not about building another house. We were talking about sort of just between children's IAPT and adult IAPT at lunch, and saying that they are quite different. And this I think nicely represents how it's different. You've got something that's existing, you want to make it better. I thought it was good, so I nicked it. So, and you've also heard a few of us say what the principles of CYPI are, all slightly different emphasis, I think, but the core message is very much the same. So it's around better evidence-based practice. It's about the clinically meaningful use of feedback tools. So using some questionnaires or forms and to get really good feedback from young people about how their experience of the therapy is going and how the experience of the service is going. And as Samir said earlier, you can do that badly by just saying, here's the form, fill it out, and say, fine, I'll give that to my manager, they'll be happy that there's another form to put in the database. Or you can do it in a really helpful way, which helps clinicians, young people and families work better together to make sure that they're heading in the direction that they both want to head in. And then there's, this is another thing that was nicked, authentic participation. This was nicked from last year's interviews, I think.
West London Mental Health Trust.
Right, West London Mental Health Trust. Anyone here from West London Mental Health Trust? Right, they use this fantastic term, which is about not just about having participation of young people and families in the service, but that has to be authentic. You have to mean it and you have to want it, and it has to have influence over the service. Then there's the rigorous outcome monitoring, which I think was sort of nicely shown in Andy and Sarah's presentation at the beginning about how that's done well. It creates this dialogue. It's used as information to create a dialogue. That's when it's being used well, and you use that dialogue to think about, okay, how can we use this information to improve the service? I think all too much outcome monitoring is used to sort of bash people over the head and say, look, here's evidence that you're not doing well enough, you're not getting all the young people and families better who come to your service, that's bad, we're going to kind of beat you with a stick until everyone gets better. Because what you get then is just sort of perverse incentives to not use the data in a meaningful way, but just to show and pretend that you're doing a really good job when you're not, and that's no use to anybody. And then there is this real issue about making sure that the small resources that we have in CAMHS, and it seems like they're getting smaller and the need is getting bigger every day, to make sure that we use the resources that we have, the limited resources we have, in the most efficient and effective way. And I think these principles are, all these things kind of fit together. So if you do all this bit well, then you have the most effective and efficient services. That's the idea behind it. This is just another next slide, which shows what I've just said in, I hope, a nice way. So this is about the evidence-based research. So it's all the stuff Derek was talking about around what we know works or is likely to work in child mental health services. But it only works if you put it together with the young person and family's preferences. So what this thing about what do they want to work on, not what the school says or what the parent says or what we as professionals might say, but how do you get that understanding of what a young person who comes to the service, what is it that they actually want from being there? And you put both those two together with a nice mix of clinical expertise and the young person, the clinician, draw on the evidence base and decide, right, this is what you want to work on. Here are some good ways that might help us get there. This is the direction, this is the therapy that we agree, this is why we agree to do it. Off we go, right? So you decide where you want to end up and you set off in that direction. But the other bit that is needed is, and we can call this various different things, but it's, might want to call it a feedback loop between all these three things. So as you set off on the intervention, you set off what you think is the right direction, but things might knock you off along the way, or you might find that actually the direction you set off in ends up not being the one you want to end up at eventually. You may want to divert off. So it's constantly having this feedback between the young person and the clinician about, are things going well, are things heading in the right direction, is this still the best way of working together, and is this where we want to be heading? We can call it feedback, or we can call it dialogue, because I think that they are the two the same things. It's about having this discussion between the clinician and the young person about, is this the right thing that we're still doing, so you stay on track. They are lots of dialogue. Right, so that's the big idea. Now we want to talk about, give some examples about some small examples about the kinds of differences this is making. I think we've heard a lot already this afternoon. I'll hand over to Alex for these next few slides.
Great. So this is just a sort of a selection of the sort of evidence of what's actually been changing in the services. So this slide focuses on changes that are taking place around the feedback tools and the outcome monitoring. So all of the partnerships across the programme are cultivating meaningful use of feedback and outcomes data, and this is alongside the sustained development of robust and efficient IT and admin systems for collecting, analysing and feeding back data. This is extremely complicated and quite costly, and it requires that sustained level of development. But it's, as we've heard, so important to be able to use the data and to be able to collect it in a really streamlined fashion. This is just a kind of snapshot of the kind of levels of data collection at the moment, and might be able to update it a bit because this is from September 2013. So all the partnerships that joined the programme in 2012 from the beginning, 63% of staff within those partnerships, so across the whole services, are now collecting feedback and outcome data, and the Year 2 sites who joined in 2013 are now, so 51% of staff in those partnerships are collecting feedback and outcome data. So moving on to authentic participation. So for the London and South East Collaborative at least, we have a really great participation workers group who meets on a 2-monthly basis, and we hear about some really fantastic work that they're undertaking. So for example, I believe this is across the Oxley's Trust. They're influencing development of the human resources policy so that children and young people must be involved in the process of recruitment. Across all the partnerships, there's lots of examples of creation of sort of various different medias. We've heard about some of the short films that are being developed, leaflets, websites, needs help to decrease the stigma that's attached with, in some places, coming to child mental health services, or we need to rename them, obviously, and also increases the approachability of services. So, for example, this is a really nice one, in Islington, the website that they now have for the CAMHS service was designed in consultation with a group of young people and staff and parents and carers, and then implemented by a young person. It was actually developed entirely for free, some of the benefits of this sort of work. As Duncan's mentioned, the feedback loops are so important. We're not going to keep getting the kind of feedback from children, young people, parents and carers and families if they don't hear back about what sorts of changes are being made on the basis of that kind of feedback. So in Haringey, for example, they collected feedback from a particular parents group. There was a parents forum which runs quite regularly, and the feedback was that in certain areas of the borough, CAMHS services are really hard to access. And they also looked at data indicating the kind of, I think it was the deprivation indices across the borough, and they saw that actually, strangely, CAMHS services were more accessible in areas of lower deprivation. So they've put together a bid, I think, with their sort of CCG, to place CAMHS practitioners within services or within GP practices in the north and east of the borough. So I think that's a really good example of how feedback leads to actual change, and all of this feedback is still a pilot, so we're waiting to see how that works out. In terms of better evidence-based practice, I'd like to give Tower Hamlets as an example. They established a parenting group. The parenting group was run by the IAPT trainees, and this was absolutely cross-agency parenting group, so it was delivered by parenting trainees from the voluntary service there, which is Dockland Outreach, and then the local authority as well, and supervised by the NHS CAMHS. They had 3 bilingual co-workers as well, working alongside the leads for the parenting sessions. So the whole training, parenting training group was delivered in 4 different languages simultaneously, and they had no dropouts over the course of all 12 sessions, which is obviously incredibly efficient, and they had some great feedback from the parents and carers involved. Okay, so this next example kind of brings together lots of different things that are being achieved through embedding the principles of CYPI. So this is in the city in Hackney. This is a sort of vignette given to me by the project manager for the City and Hackney Partnership, who was funded in part by the infrastructure money invested by the CYPI programme, and he's also undertaken the kind of CYPI service leadership training. So he noticed, this was December 2012, so they just joined the programme, and they noticed that waiting times to access Tier 2 services were extremely high. I think it was something like 32 weeks. And there was a waiting list of in excess of about 300 cases, and they were getting a lot of negative feedback from children, young people and families and referrers. So they had a bit of an exploration of the problem, and they sort of analysed geographically where the referrals were coming from, and they also undertook an audit of the clinical work patterns, and they consulted with the staff. So they said, this is the problem we have, what do you think we should do about it? What do you think the reasons might be? So in response to that, they implemented more regular performance management meetings to discuss caseloads and activity, and they saw that the staff fed back that lots of their time was spent in the community. They weren't able to kind of use sort of patient record systems and make notes and that sort of thing. So some of the money that was invested through the programme went into mobile technology, which allowed them to work more in the community. So now they're looking and aiming towards 2-week wait times. The feedback from the children, young people and families and referrers is good. And this is alongside a kind of steady increase in referrals, particularly over the last 3 quarters of the last financial year. We believe this is in part due to kind of increased need, but also much greater confidence in the actual services being provided. Okay, so finally, this is a bit of an example from Derbyshire, the Derbyshire Healthcare NHS Foundation Trust. They're actually based up in the northwest, so that's also a Wave 1 partnership. And this particular graph shows us the average length of stay in days in the Tier 3 service there. So you can see kind of a gradual decrease in length of stay. So I guess that's a kind of period of contact really also. And there's a bit of a spike there due to, I understand, when they joined the programme, they sent out their trainees. There was a bit of a delay in backfilling them, but otherwise, that's a kind of sort of increased level of efficiency, and this is also alongside the kind of embedding of a principle of collaborative practice, so that sessions are more focused on the goals collaboratively set by the children, young people, families using the service, and the clinicians themselves. And finally, just to say that referrals were steadily increasing over this time. So if you look at the last 3 years, you've got quite a sort of significant increase from 2012 to 2013. So that gradual decrease in length of stay, so what we consider increased efficiency, went alongside increased capacity for the service.
Alex, can I just add to that?
Yes.
Thanks very much. But Derbyshire were able to kind of strengthen their service with this data and avoid being re-tendered, because they were able to show that even though there was greater demand, their throughput was more efficient. So they created, I think, 12% efficiencies in what they were doing. They found that they had less DNAs, and they were treating more young people over a short period of time and taking them to a point of recovery sooner than they had previously done. And they were able to demonstrate that with this data.
Okay, so IAPT, some really nice ideas being implemented in all sorts of creative ways and done very quickly. We know that is it at least 9 years it takes for good ideas to be implemented in the NHS? Is that right? At least 9 years, and we've had 3 years. Is it 9 to 15? I know it's an enormous amount of time. So having 3 years to do it is pretty ambitious, and I think there's been some fantastic progress in those 3 years. But we don't want it to end. So this is the kind of the future gazing stuff. Some of which we have control over, some of which we don't. So these are some of the national drivers that are hopefully will help IAPT, the principles of IAPT, to continue. So was it in February the government launched the Closing the Gap paper, and in that they said there's a commitment to continuation of CAMHS transformation post 2015, which is good news. But there's no money to come with it, and it's not in the NHS mandate yet. We need to see who gets through the door of number 10 next time to see whether they will kind of follow that commitment. There's work behind the scenes to trying to get cross-party agreement on this, which I think is sounding favourable. I don't know what UKIP's stand is on this, but
I mean, you could say that IAPT was a Labour initiative and it was carried forward by the Coalition. In the mandate, there was a commitment to plan for further rollout, but there is no money in the pot. So wherever the money comes from, it's going to be taken from somewhere else. So it's that battle that needs to happen. So the business plans are being written now.
But the optimistic news is that the right noises are being made. They're not saying we're going to stop this. They're going to say we want to encourage it and we want to make it go forward.
To get the message about early intervention.
Do you mean that there might, if this were to work, do you mean there might be continuing support from the centre as opposed to through the electorates?
That is still to be discussed.
On the table still. Central support is still on the table.
What that central support will look like is different, because HEE are probably going to be, which is the going through local education boards, probably going to be involved in the future in some way.
That's the spirit it's going to get.
Yeah, that's all I know.
The other thing that's going on is, of course, the CAMHS Health Select Committee inquiry. We don't know quite what the outcome of that's going to be, but again, IAPT and the principles of IAPT are sort of coming across loud and clear. The CQC, Care Quality Commission, are still an embryonic sort of organisation, and they are interested in developing the kind of accreditation criteria for CAMHS, and they are very much being influenced by the stuff that's coming out of CYP IAPT. So like one of the possibilities of the future is that the CQC will say, this is what we want to see in a really good CAMHS service, and it'll look like a really good CYPI app service. And then there's Health Education England, so this is the body responsible for making sure that we've got the right kind of training on the ground across the health service, including CAMHS. And they, on their website, say that there is part of their mandate is to ensure that CAMHS transformation continues. And then there's the kind of ongoing support from NHS England, which we have no doubt will continue. So these are some of the national drivers, some of which we have some influence over, but some of which we don't. But it's at the local drivers where we all have influence. Every one of us in this room has influence over these bits, so we've got no excuse to make sure that these bit works well. So there's the CCGs. Just to make sure that on every CCG agenda there is a sort of an understanding and a clear strategy about what kind of a CAMHS service everybody wants. Yeah.
What does CCG stand for?
CCGs are care commissioning groups, is that right? Clinical. Okay, thank you. And the health and wellbeing boards which oversee the work of CCGs broadly. And then there's the clinical senates, who are groups of, I suppose, interested people in terms of advising the CCGs and health and wellbeing boards about saying what should so CCGs come and say, okay, we're commissioning CAMHS, what should it look like? How can we make sure we're commissioning good ones? And if things work well, if this is all embryonic stuff, the clinical senates will advise CCGs, they'll say, okay, we're going to take these sound like good ideas, and then we'll commission the services accordingly. And make sure that services stick to their what they're being commissioned to do, but again, have this dialogue about, because all these groups are there to make sure that we have the best child mental health services that we possibly can. That's the driver for all these groups. But they're all coming from these slightly different perspectives. And if the slightly different perspectives they can come from can become a battle and a challenge, or they can be a real resource to sort of say, okay, we can draw on these different perspectives and we get a much bigger, more helpful picture of what's going on than we do from each of our sort of narrow perspectives on this. Schools, so schools, the academy schools, the free schools have their own budgets which they can spend on child mental health and wellbeing if they choose. And I think we should be encouraging and influencing schools to know what good spend should look like. And then there is the CYPI collaboratives. Currently 5 across the country. We're the London South East one, which again is a great resource to draw on in terms of the different initiatives that are going on across the collaborative to think about how can we share that learning to make sure that the services are implementing these big ideas in the most helpful ways. And then there are the LEPBs, which are the local education and training boards. So these are the sort of regional groups who commission the training and education of health service staff. Alex and I have got meetings next week with the Eastern Region LEPB and later on with the London Collective to sort of talk about how they might use how we might work together to use their kind of commissioning to make sure that these people are being trained in these helpful ideas.
And we've had some really good confirmation so far from the North Central and East London that they're actually they've recruited some particular project managers to take on how CYPI apps will be, how the trainings will be funded across London.
Yeah. So really positive noises coming back out of the lectures. Okay, so in terms of education and training, we hope it looked like this. So this is a metaphor for all the different cogs working together nicely, with the CYPI principles being inputted into this well-oiled machine. So it's driven by these principles, or kept oiled by these principles, and what you get out the other side is this kind of transformation or continued quality improvement, which I think is a kind of better way of putting it, really. So that's the dialogue that's going on at the moment, and then this is okay, lost the slide. So this is now thinking about how the relationship between commissioners and providers might look. So still saying that how can we make sure that these sort of good ideas, the CYPI principles, sort of feed into this system? How can we make sure that the different bits of the system, and this is just a fraction of it, these are small parts of what's a rather complicated machine, to make sure that we do have this continued transformation, that services are still heading in this direction, that's a helpful direction, and don't kind of go off track. I think the point was made earlier that now is a good time to do it. It's very difficult to do it now because services are under so much pressure. But if we can get the structure right now, when economy kind of takes off again and money starts pouring back into CAMHS so that we're properly funded, we've got a good structure of a service in which to develop. So that's the hope.